Good morning, everyone, and welcome to our April community conversation. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX. We're so glad that you can make it today. And before I start the meeting, I'd just like to establish this meeting as a safe space. And so what that means is that every voice will be heard and respected. We understand that we enter this space with different lived experiences, and as such, we recognize the potential for unintentional harm. So we're at HealthAdvocateX, we're committed to healing should harm occur. And today I'm speaking to you from Seattle, Washington, which is part of the unceded land of the Duwamish, Stillaguamish, Muckleshoot, and Stillaguamish people. I'd like to recognize the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people and community, and pay my respects to their past, present, and future elders, and extend that to wherever you are tuning in throughout the country. So we're going to get started in a moment. And as we always do on our community conversations, this is going to be recorded and available to the public. So if you don't want to be on video, you should turn that off. We'll be taking questions in the chat. So, and certainly if you would like to also raise your hand, you may do that as well. So without further ado, we're really thinking about our community conversations going forward, not just as a COVID-19, bringing you COVID-19 information, but thinking about this opportunity to talk about public health and what is happening on public health. And so we're really pleased to have Dr. Dale Reisner, who has been doing these community conversations for a few years now, who is on our board, and she's also the former medical director of OBGYN quality and safety at Swedish Health Services. And also joining us today in honor of National Healthcare Decisions Day is Ilene Corina, president and founder of Pulse Center for Patient Safety Education and Advocacy. And we're going to be hearing from her and more about her organization. We've worked with Ilene. She's done such great work. Been working with her for over a decade. So you're in for a real treat today. And I'll do my announcements at the end. So with that, I'd like to turn it over to Dale.
Okay, good morning, everybody. Yeah, we will talk a little bit about public health. I am going to rapid fire give you current data on COVID with some emphasis on the more vulnerable populations and what the data shows us for that subset of the US population. So across the world, there's over 762 million cases reported. Again, we know that that is not full ascertainment. And deaths for that are reported at over 6.8 million, so a little bit less than 1%. In the US, it's over 104 million cases with greater than 1.1 million deaths. So we're actually running a little higher than what the world is reporting. Again, it's not clear whether our data gathering is any better than anybody else's or not, but that's what we have. And that data comes from World Health Organization and the CDC. The other things I wanted to talk about the data within the US has to do with race, ethnicity, a little bit about gender, and then I'm going to talk a bit about our vaccination data. So for race, ethnicity, just as background, obviously within the United States, there are different proportions of the general population, and I'm going to give you some of that background percent of the population in respect to the cases and the death rates. And I'm going to highlight a few. So for Hispanic, Latino, this population is up to about 18.5% in the United States now. They have had a higher rate of cases about 24% of reported cases. This makes a lot of sense because many of them are in the essential worker categories, and they were exposed, and also a little bit later access and maybe some fear of vaccination, but that is the data. But their death rate is less. And so despite the fact that they have 24% of the cases, they have 16.8% of the deaths. This
Is that
may,
because the average age is?
that may well
lower?
be
Yeah.
because of age. Yes, exactly. Although, working against them is that they're often in multi-generational living situations, and all of that. But I think age is probably what is the key role here for that lower death rate. Amongst the American Indian Alaska Native population, their percentage of the population is quoted in this data as a little less than 1%. However, when you look at the 2012 and the 2012, they were quoted as 0.9%, so almost 1%. And their population has grown. So the 2020 population estimate was closer to 2%. The data that we have here, a little bit colored in, I'm going to use the quoted background risk to compare because that's what everybody else is compared to. So 0.7 to 0.9% of the population, and their rates run pretty close, maybe slightly greater, less than a percentage point greater than their population, but their deaths are a little higher than the population. So they had a 1.1% of the deaths recorded, and that's maybe either comparable to their population rate or a little bit greater. With smaller populations, and especially with the 2020 estimates of population, and there are some real concerns that we did not get full ascertainment, both by the pandemic and the way it was rolled out. So there were definitely some fears for certain populations to report. The Asian population runs around 6%. That's been pretty consistent. Asian, by the way, does include both of the kind of more common Chinese, Japanese, whatever, but it also includes Eastern Indian. There are many people who would prefer to have Eastern Indian in a separate population, or at least a subset of this group. In general, that population does have better health outcomes. I don't know if that is based on age. We don't have a lot of elders in that population in the US. And we also have people generally of higher economic status in the Eastern Indian population. So they actually run much lower in cases and in death rates in the Asian population. As you'll possibly recall, they are the highest group, higher than Caucasian, who's getting vaccinated as well. Interesting. I don't know that we can totally blame all of the lower case rate and death rate on that, but there may be some of that in play. For the Black population, the background risk or percentage of population is about 12.5% in the US. Obviously, some states much higher than others. For instance, in Washington State, it's about 9%, 8 to 9%. They have pretty comparable number of cases across the country, and the death rate's a little bit higher than the population rate, so 12.7%. The bulk of those deaths occurred in elderly people, and the whole discussion about access, whether it's physical access or perceived fear of interaction with the healthcare system, may have played a role in that being a little greater. And then for Caucasian, we are, those of us that identify as Caucasian, or mostly, are about 60% of the population in the US. And we had higher rates of infection we had lower rates of infection overall, but we had higher rates of death. So 64% rates of death. When you break that down into gender, it's quite interesting because there are, I know that, but not everybody on this call is female, but the majority, about 51% of the US population is female, about 49% male. The females had 54% of the cases and the males had 46%. So lower cases for the males, but the higher death rate of 55% in the males and only 45% in females.
And
Lots
why,
of
why is that?
Well, I'll be really rude and say that females are the hardier gender in the country. Actually, the death rates for all causes for females are generally lower, and people don't really know exactly why that is. Whether it's
vaccination rates differences or
yes, there are, and I don't have those at my fingertips, but it's not even that. I mean, when you look at all cases of illness, part of it may be females tend to interact with healthcare in a preventative way much more than males do. And so whether there's earlier access to care, whether there's more embracing of vaccinations or other types of therapies that may ameliorate, all of the medications that came out for COVID. But it is interesting. And I think that's an opportunity more than a fact of whether it's race, whether it's gender, whatever it may be, or ethnicity, really. So I just wanted to mention those things with the numbers. And then with the vaccination rate, we were around 13% for those receiving the bivalent, and it's now 16.7% in the US, not exactly high. It is up to 42.5% in the greater than 65-year-old group, which is our highest risk. So that's good. It's not great, but it's better.
So wait a minute. 16% have
had the bivalent booster in the country, in the whole population.
Okay, so that's the last.
That's the latest. That's as of the 1st of April. And the group that is most at risk, other than those with medical comorbidities and often overlapping, is the greater than or equal to 65-year-olds, who are about 42%. There are some states that are higher and some that are lower. So I thought that was really fascinating. I'm just going to quickly mention the states. And when I say higher, it's greater than 25% for the bivalent. So it's not exactly high. Washington State, Minnesota, Maine, Vermont, Massachusetts, Connecticut, Rhode Island, and the District of Columbia all are greater than or equal to 25% for that bivalent vaccination. Those at the lowest, which is less than 10%, are Louisiana, Mississippi, and Alabama. And everybody else is somewhere in between. And you probably all know that even within a state of like Washington, where we're fairly well vaccinated, we have pockets that are not interested in vaccinating, and different, case rates and so on. In the more the vulnerable populations, the immunosuppressed, if you look at booster effectiveness, and regular vaccine effectiveness in the mild to moderate immunocompromised population. So this may be cancer therapy people or other people with multiple comorbidities. And again, moderate to severe. If you have the 3 doses of the original vaccine, it's only 32% effective in preventing cases and death.
So wait a minute. Because you said mild to moderate, and then you said moderate to severe. So in immunocompromised, moderate to severe.
In moderate to severe immunocompromised, the 3 doses, that subset is 32% effective. The booster brings that up to 43% effective. And I think you all may recall, if you've been on prior calls, that the medication that was used instead of booster or instead of vaccination is no longer effective against Omicron and has been taken off the market. So for those who are more severely immunosuppressed. So we're still down to the basics, which is go ahead and vaccinate because it's going to give you a certain percentage, especially for death. And the whole masking with an optimal mask. For really strongly recommend the KN95s or N95s for those severely immunocompromised when they are around the public, and the physical distancing. So minimize the amount of public encounters in that group. For milder immunocompromised, and I use pregnancy as an example of this, we don't have vaccine effective doses data. But what we do have, and it looks like it's much closer to the general population in terms of effectiveness, because basically, unless they've got some other issues, once they're done with their pregnancy, they're no longer considered immunosuppressed. So there's that, and most of them are younger. But if you look at the pregnancy population, and this would be either getting vaccinated before pregnancy or during, it's less than 23% for all who are getting vaccinated with the bivalent. So, and pretty much anybody's getting the bivalent who's getting current. Obviously, this would include, the data does include some who received
That's
the initial.
that's the fourth booster, right? The bivalent is the fourth booster. Okay.
Yep.
Okay.
And the Asian population is almost 33% for their rates. Caucasian is 29, almost 30%. And everybody else is less. So in the 12 to 13% or less. So it speaks again to our disparities in who is getting access to either interest in getting it or access to getting the most current vaccination that would give them the most protection. And the other thing I wanted to highlight, and then I will stop, is that when you look at those with disabilities defined as sight, hearing, mobility, cognition, and self-care. Okay, so those are the categories. And the sight and hearing are for those with some limitations, even with corrective lenses or hearing aids or whatever. So it's, that where it's not 100%, not everybody that wears glasses, but those who are corrected partially. And for 18 years old and greater, one or more vaccination dose, it's about 5 to 15% less uptake for those with disabilities compared to those without. So that's concerning, because that's another vulnerable group who either may have physical access to getting it. And the other thing that's the most maybe concerning, interesting, kind of, I guess I get it, is that the people with cognitive disability have the lowest rates of getting the vaccinations.
Mm-hmm.
So if that speaks to, perhaps, do they have enough assistance to get them what they need, or maybe they're declining because they really don't understand. And I do think that that there's probably a mix of that.
Yeah. Michael Wood also asks, any idea why the CDC is still recommending bivalent boosters when all of Europe is confining the target populations to over 50 or over 65 based on risk benefit data and high risk of other ages?
I think they're recommending vaccination for the population because of spread to the more vulnerable population. And that if you look at European underlying vaccination rates, they're way higher than they are in the US. So they have the ability to step back from everybody getting the booster, I think,
Hmm.
in a way that's different than what we have in the US. Because you can go to those places that are very low. Like if you travel to one of those states that are very low in their background vaccination rates, and you have any kind of comorbidity,
Mhm.
you're putting yourself at a little bit more risk.
Mhm.
Many of the European countries, their approach to healthcare is a lot more socialized and a lot more, reach out and available, and, not having the transportation issues, not having the cost issues, not having the fears of access that we have in the US. So I think we're different. And I don't know if that explains it all, but that would be my best answer
Yeah,
for that.
great.
Mhm.
Okay,
Yeah.
so thank you so much for those questions and
Sure.
that summation. And we'll hear from Ilene, and then if people have questions along the way, just go ahead and throw them up on the chat so that we can keep track of them and circle back around after we hear from Ilene. Thanks so much, Dale. So next up
Sure.
is Ilene Corina, President and founder of Pulse Center for Patient Safety Education and Advocacy. And Ilene, welcome to Community Conversations.
Thank you. I've always been on the viewing side, but so it's nice to be able to share a little bit here today. I was asked to speak a little bit about healthcare directives. It is Healthcare Decisions Day, April 16th. Pulse started, I just should give a little bit of a background. Our organization started in 1996 as a support group for survivors of medical injury. I started after the death of my son in 1990 from a preventable medical error. He died from a tonsillectomy. He bled to death after surgery for a full week. And during that week, we went to many different doctors and hospitals, and they each said, "Don't worry, he's fine," until the 8th day he died. Going to support groups for parents of lost children was very difficult because I was angry at the same healthcare system that everyone seemed to love. You respect the healthcare system, the people who work in the healthcare system. I liked the doctor. I liked the doctor even after the terrible incident and experience, but I wasn't allowed to talk to him anymore, and we were shut down. So I felt like nobody was going to learn from this experience. And by starting a support group and helping people tell their stories, we were able to learn what actually happens at the bedside, not reading textbooks, not learning from healthcare professionals, but learning from the patient's experience, what can go wrong and what was going wrong in the healthcare system. And our dream back in 25 years ago, this is now, was to start a country of people helping people and patient advocates. How do we help people help people? If there was somebody like myself back then, could I have called someone and said, "I don't feel like I'm getting a good answer. What are my steps?" And that's, for at least the last 20 years, that's what's been happening. People call us and say, I don't feel right about this. What can I do? What are some of the conversations I can have? What are some of the questions I could be asking? So that's really the background of our organizations. We now have 3 programs a month that some of you I see there have been on our programs. They're all about being a support person, a caregiver, and a patient, not necessarily a professional patient advocate, because we want people to think about becoming a patient advocate, a professional patient advocate, but that's not always where they start. So we have a real mix of people who come to our programs, and that's what we want to continue. So when it comes to things like the healthcare advanced directives, I'm going to use specifically the healthcare proxy form that is filled out. That's part of our Take Charge campaign, and this started 3 years ago. We decided that we needed something to focus on, and it really was around the time of the Me Too movement or Black Lives Matter, when things were coming alive because of bad outcomes. We were never going to see on the front page of the newspaper that somebody died from the wrong medication, or somebody died because, or was injured because of the surgery error or an infection. That was not making the front page. We had to make it important. And we recognize that every time we go into the healthcare system, as vulnerable as we might be, and as complex as it is, healthcare providers are still responsible 100% for any errors and misunderstandings that happen. And we have to make it so that the public, the patient, goes into the healthcare system better prepared and takes some responsibility for their own safety, know their medications, know what their medical history is. And that's what is missing, I believe, still in the healthcare system. So when it comes to take charge, we worked with public health students of public health at a local college. It was the kickoff date was the day that the country closed down, or at least around here closed down, because we had a date in the library set to meet with our state senator and have a big event, and they canceled it that day from COVID. But the idea is that there's 5 steps, the 5 basic steps that we hear about most often for patients and their family members to prepare to become a patient. Our kickoff is in March, which is Patient Safety Awareness Week, is the second week of March, where we talk about all 5 steps. And then April is step 1, which is advanced directives, specifically, again, the healthcare proxy. And then just to go through the steps, step 2 is prepare for your medications and your medical history. Step 3 is, I still have to cheat, make a list of the questions for your doctor and your symptoms. Step 4 is ask caregivers to wash their hands to help avoid infections. And step 5 is be an advocate and use an advocate. So those are the 5 steps.
And can I just jump in here to
Yeah.
say, because we've also been, obviously supportive of this campaign, and for many of the people on the call, none of these things would be surprising, but I think what you have effectively done and what the campaign does, and people on the call should be really familiar with and have your website just at the ready, is that you make it very simple, direct, and accessible for any person to utilize the great materials, and also the words that you've set up. It's just very, very accessible.
Thank you. And the idea is that for somebody who wants to promote an advocacy in their community, could use this as a presentation. We've had people, and I'm doing one on Friday, I've done many presentations, to do presentations in the community talking about the 5 steps. And if we were all talking the same language, then we're all helping patients and their family members prepare to enter the healthcare system. So what I have found, and I'm going to start with step 1, which is the healthcare proxy. We purposely started April as healthcare proxy because of Healthcare Decisions Day. We wanted to stay on top of that. The idea is that at 18 years old, first of all, at 18 years old, the patient and a young person becomes an adult. And we want to assume that their family members, their parents, could still talk for them. Well, college students were really shocked. And even the staff in the college, when they talk to them, are shocked that their parents are paying the bills, but they can't speak for them if they can't speak for themselves. And a student who's sick or injured in college, far from home, really needs to have a healthcare proxy. I had this experience myself. My 18-year-old got into a car accident halfway across the country. He reached his brother reached me. I called out to the hospital and they would not talk to me. Now both my adult children, in almost 30 years old, carry a healthcare proxy form with me as their proxy to speak for them if they can't speak for themselves. And the reason we use that as advanced directive is, remember, when somebody goes into the healthcare system, whether it's a hospital or a doctor's office, they're going to be asked then, who is the person who could speak for them? And that's not the time to plan this. So we're not talking about, although it's important, power of attorney and living will. This is all important stuff also. But it's that form that's going to be handed to somebody unexpected. As an advocate in the past, I think since about 2006, my advocacy has been at the bedside, and I focus only on safety. I've been asked way too many times to be someone's healthcare proxy that I don't know. And when
It's
I
just
sign,
incredible.
right?
It's
Because they're,
incredible. Yeah.
I mean, I can picture patients with their hair, in their cap, and their IV is started, and then they're handed a form. And I have to, when I do sign, because I say, well, we have to talk. We need at least 5 minutes to talk. At least who's the person that you want me to reach out to for you? Um, but we need to have that prepared in that conversation. And I sign off only through surgery, only through this procedure. Don't keep me on. You guys have to prepare. Now I know to make sure they have this long before they go into the healthcare system. So the healthcare proxy form is something that we want people to have at 18 years old to start the conversation. We do something called the Healthcare Quality Project, which is working with vulnerable populations. What I found very interesting is we do a patient activation discussion group with specific groups of people. When I met with 13 people with HIV or AIDS, one of the things that they checked off, they have an opportunity to check off up to 50 questions or things that they want to talk about. Most of them checked off that they wanted to talk about the healthcare proxy. And when I said, who wants to start the conversation, because I don't know what they want to talk about, I don't pretend that I know what their concerns are, nobody would answer. And finally, somebody spoke up and said, how do we choose a healthcare proxy if we don't want someone to know that we have AIDS? And I thought, there was 13 people in the room. They all started talking amongst themselves. And I said, somebody come up with the answer. And they did. They were able to have this conversation. But then I reached out to the HIV support groups I know of and said, here's a conversation you guys need to have. You need to start thinking about who will be their healthcare proxy. They need to have this conversation. So that was some of the experiences that I've had with this that I think is really important to recognize. It is a great conversation to have. They say during the holidays, I've had the conversation with my kids. We need to make this part of our conversation. And remember, when it comes to COVID, and we see people on vents and they're intubated, they can't speak for themselves. So I like to remember that the healthcare proxy is not about death and dying. It's about how you want to live. And on the website, the Take Charge website is takecharge.care. There's a whole section on questions and comments and things that we can do for this. We also have a picture on there of we have a video that the college students have done. And one of our volunteers has had a going off to college event with about 10 children who were in 12th grade. They were going off to college, and there's a picture on there of all of them holding up their healthcare proxy. They had the
I
conversation,
love that.
invited the families in. So they all had their healthcare proxy form filled out at that time. So it is a very serious thing because we want to be taken seriously as patients, but something that somebody can do as an advocate. Remember, this can be done remotely. It doesn't have to be done at the bedside. It's a conversation. It could be a conversation starter for someone who's thinking about becoming a professional patient advocate. They can have that conversation and just say, well, let's start with your healthcare proxy form. Let's talk about it. So those are some of the things, again, that that we want people to understand about this. And of course, the Take Charge campaign, we're hoping that if you have articles, we do memes, we do stories. If you put yours out there with the Take Charge logo, we will repost it. And we want your information on there so we could say that more people are involved with Take Charge. It's not just one group. We have a video on there that Robin was part of, but we made this video, a fun video. And the first thing we did was this Take Charge video, and it was very lively, and it had each of the 5 steps discussed on there. I think it's 6-minute video. It's not long. So if you look at that, you'll see that it really is a grassroots patient safety and advocacy movement, and we want people involved.
It is, and it is also has a lot of very credible organizations that have used it, like the Joint Commission, which I think is very important for people who, maybe if you're a professional advocate and you're looking for different tools to talk with your clients or family members about these various different, topics, the Joint Commission. I mean, I don't know if there's a more credible organization to support something like that. So do you want to tell us a little bit about that for people that might not know, Ilene?
Sure. Well, I was on the board of the Joint Commission from 2005 through 2018. And when I was
And can you describe what the Joint Commission is too?
Sure, the
For people
Joint
who don't
Commission.
know. Mhm.
Yeah, absolutely. The Joint Commission is the largest international accrediting organization. They set standards for healthcare organizations, for hospitals and nursing homes. Many organizations, healthcare related. Some people talk about the Joint Commission as an organization that comes in, they can close down a hospital. That is so untrue. It's not what they do. I've stopped conversations there. They do look at certain standards, and not every single standard. I think they have 500 and something standards. So it may be that they look for patterns of problems in healthcare. They don't, if somebody dies, that's not the place that's going to go in and change everything. And I will tell you, being on the board of the Joint Commission made me really recognize the importance of not punishing healthcare organizations, but improving healthcare organizations. And the Joint Commission does that too. So it is a place where you can file a complaint, and they will look into all complaints, but it is not something that, but it is very well respected in the healthcare system. In most cases, it's very well respected. They approved within their board the Take Charge campaign. And they did podcasts, they did flyers, they did the first year, they did a tremendous amount of advertising in their lobby. I just got a case of pens that they sent. They did pens for that. And then they went out into the community and talked about Take Charge. And on the website under patient resources is the Take Charge campaign, the 5 steps. So they also have come up with the Speak Up brochures and the Speak Up campaign that's out there. So this is really, so grateful that they took this very seriously, because they recognize how important these 5 steps and simple these 5 steps are. Another organization that has taken it very seriously is Memorial Sloan Kettering Cancer Center. They have done within their staff, they have done 5 or 6 videos on each of the 5 steps. It's not public because they use their patients and their staff to promote each of the 5 steps. But they put a lot of resources into that. I do believe that there's conversation about them, putting it out into the public in the future. But right now they can't because of privacy issues and the patients that they use their voices. So they've also taken it very seriously. Ideally, if we're in conversation with a couple of other healthcare systems across the country that are interested in using the 5 steps. I believe research can go into this. This could be a great opportunity to research people doing this and using the 5 steps for improvements. And again, I'm always going to say that we have to be better prepared as patients and as patient families, caregivers, and advocates in making sure that that the patient is prepared. I'll tell you, the whole idea came from me sitting at a patient's bedside, an older woman who was about to have surgery. And a nurse said to her, I need a list of your medications. And she said, oh, don't you have that? And it got me so angry. I mean, it's staying with me today. This has got to be 5 years ago, that we went through this. What do you mean you don't have your list? I didn't have her list. I should have, but she gave it to her husband, who was waiting out in the lobby, and she did not have her list with her. So it really became, why would you expect the healthcare providers to get it right if you don't even know your own medical history, your own information? And we have handouts, and we do health fairs now, and this is really what we're focusing on as far as patient safety. Requesting, I don't want to say requiring, but requesting that the public is better prepared to be a patient. And of course, in September, we wrap it up at Patient Safety Day, the World Health Organization. But August is use an advocate, be an advocate for others. And hopefully we can all take a piece of this and run with it and look for advertising or put your own information out there with Take Charge logo, and we will pick it up. You'll see that it's out there. There's a Take Charge on LinkedIn and I think on Twitter there is, and Facebook. So we hope that people will get involved in this.
So additional tools to, again, that could be in anyone's toolbox to help be prepared and empowered, competent, and confident, I think is what we say. Competent and confident to communicate with healthcare providers. So I mean, you have so many great experiences at bedside of what you, you know, great lessons. And I'm so sorry for the death of your son. And that story is just heartbreaking and really grounds us in why this is such important work. And just really grateful that you've been able to touch so many people's lives. What are you seeing today, in the post-COVID, we want to say post-COVID, even though we still have COVID, hospital setting that you feel like is maybe, popping up in the last couple years that's been different from previous years?
Well, I think the lack of visiting hours is a serious problem, that all of a sudden now, where visiting hours were so important before, they're closing the doors on family members and expecting a patient to come out of surgery and understand the care that they're going to get at home and understand that the medication or what was done. Visiting hours around here, there's 2 people I've been visiting in hospitals, and one of them is 10 a.m. to 8 p.m. and the doctor comes in at 6 a.m. to visit the patient. And we've been doing something called remote advocacy. We have a video and a page on our website for that, where we leave the phone open 24/7, and it could be done with a team, as a team. So if a patient is in the hospital, we suggest that they leave their phone open. I will leave my phone open, and I can listen all day to when the nurse comes in. I think a lot of family and friends are used to the patient saying, "The doctor's here, I got to go." And what
Right.
we want to say is, "The doctor's here, I need you to stay. I need you to listen. I'm putting you on speaker," and start writing. And if every person did that when they're on the phone with a patient in the hospital or doctor's office. So somebody asked me the other day, "So you're saying my husband should go into the doctor's office and he'll call me from there?" He's got to call you in the waiting room, because the doctor's not going to say, you can't say to a doctor, "Hold on a second, I'm going to get my wife on the phone." It's got to be done in the waiting room, and you've got to be ready to leave your line open and not be calling the family from the doctor's office. So this could be done long distance, but the idea of not being able to be with family is very concerning. But I also am concerned about the lack of training for family members. Quite a few people have, and we do this training, this 8-hour training. I've had many people say, "I am my husband's best advocate. I will scream and yell at the doctors until I'm blue in the face." Well, guess what? That's not really doing the best. Is that really what
Not
you're gonna
helpful
do?
very often.
Right, right. And people really think this. I'm sure most people have heard that conversation. And we want people to not be that. We want to be an ally. We want to assume that they have the patient's best interest, but sometimes they need to be reminded. And we do this. I'm sure many people have heard about how do you ask somebody who's just spent 10 years in college to wash their hands after when touching a patient. And we use, I have a cup here now that I give out. I leave in the patient's room. I just dropped a whole bunch of that says, because I'm all,
Yeah. Oh, there we
it
go.
says here, "Thank you for washing your hands. Please help yourself to a Twizzler as a thank you." And we fill these with chocolates and Twizzlers. So Twizzlers
Oh,
is our
nice.
go-to.
Wait, I want to take a picture of that. Can you just keep it up and
I'll
I'm going
send
to
you a
take a
couple.
picture
Send
of
me your
it.
address. I'll send
I
you
want to
some of
take a
my.
picture of the cup.
Is it,
There you
is it
go.
showing up?
Yeah, it
Is
is. It is.
So we want,
It's perfect.
I just dropped a couple of these off with Easter candy in it for the staff. but it's,
Right. Yeah,
you know,
I got it.
it makes
I got
people
it.
laugh. It
Yeah.
makes people laugh. And when you see all these nurses and doctors walking around with Twizzlers in their breast pocket, you could thank them for washing their hands. So we encourage people to, you know, a lot of people think you're crazy for doing something like that. It makes no sense. But if it works, you try it.
Yeah.
We
Right.
want to make light of it. We want to be an ally in the healthcare system.
I have a question about this. I haven't ever heard of somebody keeping their phone on 24/7, although that's a really interesting idea. Have any hospitals pushed back from a privacy perspective or anything else?
I've only done it maybe 4 times, and
Uh-huh.
I haven't had to keep it on 24/7. I will keep it on all through the night where I go on mute. I shut off my video. Their video stays on, looking at the ceiling. It's on their table. No, absolutely not. And as a matter of fact, they seem happy about it.
Hmm.
Um, I had some, you know, could you talk to her, talk to the phone? I have my advocate on the phone. And they do. I've actually watched people changing the bedding because they lean over the table. They don't realize that it's on. So I'll see the nurse or somebody leaning over. But for privacy, no, because we're not looking at their body. We're looking, usually it's always on the
Right. Yeah, I'm
counter.
just wondering if there would be any reason why a hospital wouldn't want this. And I don't know, Dale, if you're still listening in on this part of the conversation, but I'm just wondering if there'd be any reason why a hospital would not allow that. So,
And it's not a secret. Remember, we
yeah,
want them to tell the nurse or doctor that we're on the
yeah,
phone.
Yeah, I think they, if you have a phone on, it's one thing. If you have your visual on, there may be some concerns about that. Everybody in the room just needs to know and agree. Because we do have some staff that don't want to have anything recorded, or certainly their video, like the person reaching over the bed, having a picture of, you know, their chest area as they make the bed or whatever. People are sensitive to that. And most hospitals do have rules around what can be recorded and what cannot. So I don't see a problem with it. I think that it's an interesting idea. And even if it can't be on all the time, the concept of ready access is super important. So if you ran into something where they said, no, you can't do that, the fact that the patient's phone is close at hand and you're readily available, would, take care of most of that, I would think.
And none of this, Dale, is being recorded. We're online and available, but we're
Yeah,
not
but they don't
recorded.
know from their end. That's
Right,
yeah,
right.
yeah.
I mean, we have to be
So
honest. As a
I,
professional, we're honest about it.
I get it, and I respect you, and I don't doubt that you would not do that. But we've seen people sneak things. We've seen family members do videos of things that we've asked them not to do. So hospitals are sensitive to that,
hmm,
probably more than they need to be. And I wouldn't want it to interfere with your ability to stay connected. And,
Right.
yeah. So I think just full transparency is really the answer to that. Ask ahead of time, make sure everybody's on board with it. If they're not, come up with an alternative that will work, so that the patient is not left alone.
Right,
Uh,
absolutely. And not long ago, I heard I knew that the nurse came in, gave the pain medication at 3 a.m. The patient woke up at 6 and said, I'm in so much pain. They never came and gave me my pain medication. I was able to say, yes, she was in at 3 o'clock. Another time, the nurse was explaining the medication. Now, one of my hangups is when they call pain medication, they don't call it an opioid if it's an opioid. And that, I believe, and that's the whole addiction issue, is that people are not being told if it's a pain medication, it must be Tylenol. But I believe opioid is a term used for healthcare providers and the media. It's not a patient and family term. So if I had to look it up a few years ago and say, what kind of medication is an opioid? I thought it was like a Tylenol. So when I heard the nurse say, we're going to send you home with pain medication, I was able to say through the phone, because the patient was groggy, is it an opioid? And she said, yes. And I said to the patient, do you want to take an opioid? And the patient said, no, I don't want to take an opioid. That changed the whole conversation. And the
Yep.
patient would have been taken home a medication that she did not want to take. So that's something to clarify, and make sure that we're thinking clearly and making sure the conversation happens appropriately.
I think you're right. And separate from the opioid, on top of the opioid, is all patients should know what they're being given.
Well, they're
Yes.
being given a pain medication, and that's good
No,
enough.
no, I mean,
Most
any
people are.
medication, they should understand what it is and what it's
Yeah.
being given for. Right.
Yeah.
And
Yeah.
that's step 2. Keep a record of your medications is step 2. So having your own record is
Mhm.
part of that, educating them and keeping that information. So absolutely agree.
Yeah.
Right.
And Patsy Stahl, who's on the line, said that there's a notice in every exam room, in the medical organization that she's involved with, saying no taping or recording allowed. And what I think is so interesting about this strategy, which I hadn't really heard about before today, was that you're not taping or recording, you're just being present. And that's pretty cool. That's pretty cool. I think that's a really
Yeah.
good tip. Ilene, thank you for
Yeah, I don't think
sharing
it's
that.
appropriate personally. I definitely don't think it's appropriate to tape somebody that, and sometimes if you ask the doctor, can I tape you? It shouldn't be done from the phone. It should be done from the patient's bedside.
Yeah.
So,
Yeah.
I don't even think I never even thought of that, because it was never something, because I'm
Yeah.
taking notes. We don't need to tape it too. So,
And you're an honest person, so that helps, right? But
right.
yeah, people will cut things out that are there and present stuff that's you name it. I mean, you watch and see what's in the media. There are people that will do things to their own advantage, and
Mhm.
so it's sad and frustrating that we have to even talk about this, I think.
But it's
I'm,
true.
I,
And
yeah.
the media does it too. If I'm interviewed, they're going to use the one sentence I wish I didn't say. And I just talked for 30 minutes. Why'd you use that one sentence? That's the one thing.
Yeah.
So yeah.
So we did have a question about how to reach your organization. I just wanted to let people know that that is posted in the chat, and I just want.
And Take Charge is separate website. Takecharge.care is if people want to use that or attach to it. We only thing we ask is that it's not changed, and those 5 steps stay those 5 steps. We don't start adding. If some people want to add falls to the 5 steps, then they might want to add it to the medication safety and put it through that way. We don't want to make it into so confusing, because there's so many more things that we need to do to stay safe. But by starting with these 5 steps, it's a great way to start the conversation, I think.
That's wonderful.
This is fabulous work, really fabulous work.
Well, thank you.
So before we wrap up, we have about a little more than 5 minutes. I just want to encourage anybody to ask a question. Michael Wood asked another question, which is, can you talk about how your methods are used before someone ends up having surgery in the hospital, i.e. assuring full disclosure and using informed decision-making before elective things are done? I think that's for you, Ilene.
I'm not 100% sure I understand, but if somebody comes to us about having surgery, my first question is, who is your support system? And because our advocacy is really called family-centered patient advocacy. So usually, like, I'm working with one group now where there's about 7 women on a messaging thing with one woman who's in the hospital, and everybody is taking a piece of helping her. And that's the perfect scenario, because they're all helped. So if somebody's going in for surgery, the first thing I want to know is who's their support system. And then we start to work with them. I like to think that we don't say to someone, here's what you need to do. It's, here's what I will do for you. Here's what I can help you with. I could look up your insurance. I could find out who's your insurance. I could find out the process. I'll go look up the process of the surgery and see what it looks like. I'll look up the doctor's background, who's done the surgery. I'll go with you with questions, what we could be doing for the patient. So I don't know if that answers the question.
And I think Michael was trying to get at 30% of healthcare is inappropriate or unnecessary. And does Pulse help with helping patients and family members try to decipher what is really necessary healthcare versus unnecessary? Is that anything that
Well,
your organization focuses on?
well, if somebody's getting a hysterectomy, we might ask why you're getting it. Have you gone for a second opinion? We
Mhm,
stay far away from medical decision making and
mhm,
opinions, and even we also discourage recommendations of what we'll share is this is what I've heard done for me. This is what's worked for me. At all our programs, we go through this disclaimer of share what has worked for you or what's worked for other people. Not we don't use the words like you should, this is what you should do. You should go for another opinion. You should, it's, have you thought about going for another opinion? Have you thought about the necessity of this surgery? What are the outcomes? Have you asked the doctor? I love asking my doctors, how many complications have you had? I just had a colonoscopy and I said to her, how many complications have you had? And she said, I've had about 10. And what happened and what did you do with that? And she told me that only one ended up back in the hospital. And she was very honest about it. And it made me feel very confident that she had an injury and she took care of it. Not, all my patients are dying. I'm not expecting that. But when having the conversation, you want to feel, I believe, I want to feel that they are going to have this conversation with me. And I encourage patients to have those conversations. Ask him. I Googled doctors. I just found a doctor that was been sued like 4 times and suggested to the patient that they Google their doctor. I didn't tell them not to go there. And trust me, I've used doctors that have had lawsuits. I don't make them into bad doctors. I just want to know if they've learned from it. Because I
mhm.
would have gone back to the doctor that did my son's surgery if I thought he learned something from it. It might have made him better as a surgeon, recognizing that somebody could bleed to death after a tonsillectomy.
Yeah, yeah. Um, so Dale, thank you so much, Eileen. And it's just been it's always interesting. I always learn something or some things from you whenever I'm involved with you. So thank you so much for sharing your
Thank
wisdom
you.
and your tips. And I do hope people will go to your website and look at it, your additional information. And Dale, before we wrap up here, are there any remaining thoughts that you would like to share with our community?
Well, I think first of all, again, another thank you to Eileen. I think your approach of asking questions rather than telling people what to do has to be the way we do our best advocacy is being there to support them, make sure they haven't forgotten something they should be asking about, and doing it in a very neutral way. So that is fabulous. The other thing I just want to say is I know we've talked a lot about COVID. COVID is not endemic yet. We have to get down to less than 100 cases, 100 deaths per day in this country. We're running, the lowest we had on April 5th was 253 per day. And through the month of March, it was running closer to 280 on average. So we're getting there. But my biggest thing is public health. And I think our discussions will be globally more public health. You'll hear a little bit more about what we know about long COVID in the near future. And that our focus from these community conversations will be a lot of public health orientation. So remember that what everybody does as an advocate with a one-to-one is not really public health. It's personal and it's individual, and it's incredibly important. And the public health side is looking at whole populations and either doing research or supporting prevention and community health. So what the individual advocate does and what public health does more on a larger scale are complementary. And I think it's helpful to use this platform to talk about those two ways to try to work on this.
Yeah, that's great. And thank you so much for continuing to educate us and provide credible, relevant, actionable information to our community, Dale. We're just very grateful to have you. So I just wanted to close with saying that I hope that you all will join us for our next community conversation, which will be May 8th. We will have Dr. Reisner back with Michael Millinson, who is an internationally recognized expert on making healthcare better, safer, and more patient-centered. And he's the author of critically acclaimed book, Demanding Medical Excellence, Doctors and Accountability in the Information Age. He's also an adjunct professor at Northwestern University's Feinberg School of Medicine. So the registration, of course, it's always free to attend that. And we hope you'll register and also share the registration. It should be a really fascinating conversation. So also wanted to say, if you are a member of Health Advocate X and haven't registered, or let us know that you want to register for the case review April 13th, which is later on in this week. We have a really interesting case coming up. So just let us know at info@healthadvocatex.org if you are a member. That is a free benefit of membership. Okay, thank you so much. And we'll see you next month. Take care.